So I'd like to thank you all for joining us on this combined WONCA SIG for Family Violence, Emergency Medicine and Women's Working Group presentation on chemical submission and drug-mediated sexual abuse in the 21st century. We've got 3 speakers tonight. We're going to start with Dr. Elena Klusova, who's a specialist in family and community medicine and a consultant GP with a focus on emergency medicine. She works with the SAM 061 Mobile Intensive Care Unit and Helicopter Emergency Medical Service in Ibiza, Spain. She's also the chair of the WONCA Special Interest Group on Emergency Medicine, a member of the WONCA Special Interest Group on Family Violence Steering Committee, and part of the WONCA Working Party on Women and Family Medicine. She's internationally recognised as an educator on chemsex and chemical submission. So I'd like to welcome Elena now, and we'll introduce our other speakers just a little bit later on. Thanks, Elena.
Thank you very much, Jenny. Do you hear me well?
Yes, perfectly, nice and clear.
Okay, let's try to share my screen and hope everything works good. Do you see it correctly?
Yes, that looks good.
Okay, fantastic. So, wait. Okay, so let's start. Good morning for the Europeans and good any time of the day for the rest of the planet. Thank you very much for being with us. So we are a joint team of the Emergency Medicine Special Interest Group, of the Family Violence WONCA Special Interest Group, and the Women's Working Party. So we will speak on this theme, which is the chemical submission and drug-mediated sexual abuse in our 21st century. Let's speak what is it about. Firstly, I wanted just to introduce you some sources of materials from where I've got quite much information. You can see here lots of organizations, among them some databases, NGO associations. There are some sexual health clinics in all Europe, in Madrid, in London. There are lots of institutes like National Institute of Drug Abuse or the European Union Drug Agency. So all these sources were used to create this presentation. And also, just to remind you that we are living in 21st century. So all these new information sources like Wiley Open Library or OpenAI or ResearchGate, so everything helped to create the material for this presentation. And coming to the substance, let's see. The use of chemicals to manipulate our willpower is nothing new for the humanity. And the use of drugs to improve the quality of our sex relationships or to encourage the sexual intercourse is a classic practice, classic theme in the human history. But in the large cities, let's say mostly in the large cities, the voluntary consumption of sexualized drugs by men who have sex with men, MCM, and the use of chemical submission for criminal purposes, regardless of sex, are becoming a real legal and public health problem. So the consequences of this event are overwhelming in nowadays time, the judicial system, and they appear in the primary care consultations, start appearing in the hospital consultations, and even in the emergency rooms. So wanted to speak to you about the 2 pillar concepts when speaking about the use of chemical substances for sexual purposes. One of them is chemical submission, and another, the chemical vulnerability. The chemical submission is something what all of us understand quite easily, what is going about. And this is the administration of the substance involuntarily to the person to affect the psychological capacity of the victim and having the criminal purposes. Meanwhile, the chemical vulnerability is not something what we are used to define. Let's see. This is something where a sexual offense is committed against a victim who has voluntarily consumed some type of psychoactive substance. And let's think a little about this event. Who of us hasn't had a shot of tequila to warm up, to get courageous, or to lose inhibitions when going to a party? Who among us hasn't drunk several rum and coke shots, ending at completely drunk in the wedding of our best friend or in the birthday party? Maybe some of us can recall having sex with a cute stranger after getting drunk in the nightclub. Well, we were young, we were silly, few experience. But the fact is that the experience of the chemical vulnerability is part of our lives. Even if we don't give it a name, it is something what we are used to see and in many occasions practice in our everyday from our young age. But this vulnerability has reached its peak in a gay society among men who have sex with men. This peak got the name, a specific name, and the name is the chemsex. So I have quite sad pleasure, let's say it is quite doubtful pleasure, of presenting to you the phenomenon of chemsex. Here goes a small video. So quite a shocking video, I think. Here is the definition of the chemsex. And they are practices of massive sex marathons, which can last 2, 3, 4, up to 5 days at private parties, apartments, villas, boats, saunas, which with a simple mobile app can attract a large number of guys participants, and which are prolonged and intensified by the use of multiple easily available and affordable drugs. And when I speak about the multiple easily available and affordable drugs, I have my personal experience with this because working in the Ibiza island, in Balearic Islands, I oftenly I'm called to go with my advanced life support ambulance to make like preventive services in the private villas. So there, in these private parties, in the luxury villas, the ambulance and the drug dealer's car oftenly are packed together, are packed one close to another. So it is quite often between us that we go to the drug dealer, that we present ourselves, and that we ask, well, what did you bring new today? And during the party, meanwhile, there are some health issues coming up. We go to the dealer saying, look, what was that you gave to that person? If you know, it is not doing a really, really good service. So imagine which is the dynamics of these kind of parties that we're experiencing. I want to explain you which drugs are used in these kind of practices, and firstly to analyze the requirements that these drugs must fulfill. When we speak about the drugs used in chemsex, we are looking for drugs that produce euphoria, disinhibition, and emotional excitement. We're looking for something that increases empathy, desire for socialization, and communication skills. These drugs must boost confidence and self-esteem, and possibly they must be fast-acting and long-lasting. Let's think just about these four first requirements which the drugs used in the chemsex are looking for. They are quite positive, quite nice, quite productive, let's say, objectives. When you go to a party, when you go to a birthday party, when you go to the wedding party of your friends, when you go to the working meeting or working dinner together with your companions, it is quite normal that all of us human beings, we would like to be accepted nicely, that the people like us, that the people feel that we are interesting in our conversation, that we are good dancers if we are in the party, that could be we are funny, that we have nice sense of humor, that we are intelligent. So these boost of confidence and self-confidence and the potentiation of the socialization or communication skills really are very nice and absolutely legal objectives. Let's see more requirements that the drugs used in chemsex must fulfill. These ones, being sexualized drugs, are created to increase libido, particularly the desire for sexual pleasure, and prolongs the sensation of pleasure. Also, it is quite interesting objective when we're speaking about our private sexual life. They look for increasing, and they can increase the sexual potency, which is also something what is quite good objective when we're speaking about the intimate sexual life of a couple, for example. They normally have one extra useful effect, which is the relaxation of smooth muscles, and we're speaking about the relaxation of the anal sphincter. Okay, we're speaking about something, the practice made by men having sex with men. So really, this has lots of sense. And these drugs reduce the fatigue and tiredness, what is amazing. They are very easy to obtain, they are absolutely inexpensive, and they allow huge amount of mixtures and meshes. Let's speak about who and how. When we speak about the statistics, 96% of all the guys who are doing chemsex are homosexuals, and actually this term was invented on particular to speak about men having sex with men. And it is not that we, women, don't use drugs, alcohol, any kind of psychotropic substances for sex. Evidently we do. But this term, particularly the chemsex, was created for this activity, for the men having sex with men, and these 4% of these non-homosexuals, they are transgender guys. The majority of the guys who use these drugs are single. And what is interesting, many of us, we can think that this is something what just adolescent guys are doing when they are silly, stupid, and when they are looking for the new experiences in their life around 14, 15, 16 years old. No, it is not. For this practice, for the chemsex use, the guys who are using them are between 30s and 40s. 35-year-old is the average age, let's say, but you can easily find in the chemsex parties quite adult men of 50, 60, and quite older than 70. And what is very interesting also, it is that the majority of the men who are performing these practices have the university education. They are almost 70% of these guys. So it is not that they are not educated, not knowing how to read and to speak. No, they are highly educated guys with good jobs. When we are speaking about the percentage of the people with really good social and economical position, they are around 83 or 84%. Now let's think about who, why, and how. Speaking about how, I would like to, let's say, introduce you the term of Gaymojis. Actually, there is nothing to introduce because this is a keyboard originating from Grindr dating app, which the gay men use since quite 15 years, I think, or 20 years. You can install this keyboard in your telephone, just 100 emojis for free, and around 400 of them you can do just for $4 or $3. The Grindr language now can be extended to all the media. We use it widely in our WhatsApp in every day. We use it in e-message, in the Facebook, in the Instagram. So some of these icons are quite really usable and really can seem to be very innocent, but many of them, let's say, are much more delicate than you can imagine. I will explain it to you now because I will show to you just some examples of them. So this seemingly harmless keyboard has a very close relationship with the fast, cheap, and in many occasions, very low quality consumption of sexual dates and experiences. In the gay world, there is a lot of consumption related to sex. A consumption that when you are young, you can pay with your body. And if you get older, you will have to pay with your credit card. So here are some examples of these Gaymojis, which we've seen millions of times in our Instagram or Facebook accounts. Any example, I don't know, for example, the sign which seems very pure and very innocent of the recycling, actually in the gay world means the versatile group sex. When we are speaking about closed fist, which many of us we perceive as a good and noble gesture of support and struggle together, actually in the gay world means fist fucking or fisting. How many times we used the symbol of a small fire, let's say, in our conversation, and it results that this symbol has a specific, very explicit and very shameless meaning of coprophagia, of scut, of golden shower, which is sexual practice that involves the use of the urine and excrement in erotic play, and the bareback. Here is another example of something what really surprises with its clarity and with its boldness. We see here like lots of smooth pink apricots and eggplants of all sizes and colors of human skin. But what is really shocking, for example, is the audacity of some symbols, like the shameless symbol of the nose squirting a fat drop of popper, or the T letter, which is the meaning of Tina, which we will speak in the couple of next slides, or the symbol of tombstone in the cemetery with the initials of the mephedrone, one of the drugs used in the chemsex. So when we speak about the Grindr and all the applications which connect gays with the sexual purposes, all these is shamelessly focused on sex in explicit and elevated to a higher level that any non-gay human being could possibly imagine. This reinforces our idea that gay people only think about sex non-stop and of eating eggplants and lots of eggplants, let's say. So the hypersexualization and trivialization of gay people is reinforced by the stereotype that they are driven just by economics, self-interest, fun, and sex. And now we are coming to the why question. Appearances can be deceiving, and not everything is what it seems, because the chemsex tends to be a product of loneliness and lack of confidence, whether due to or not one's sexual orientation. And these addictive practices many times are refuge for many men who struggle to accept their homosexuality, although, to tell the truth, the problems goes far beyond just this. So here are the problems which we can find behind the apparently shameless and explicit consumption of chemsex that are sought to be solved. Let's see. Before naming you these problems behind the consumption, let's just imagine ourselves, analyze ourselves. We all have our big or small insecurities and complexes. Some of us are too chubby, others we are too thin, others we have small breasts, others have a small or crooked penis, we sweat too much, we are bald or too hairy, so many complexes. Some of us are introverted and we don't know how to tell jokes, and we are really not what is called the life of the party, and we are not so very sympathetic and we are not so very funny. How many of us demand too much of ourselves and punish ourselves or condemn ourselves for not meeting certain attractiveness criteria? So, thinking about this, look which problems are behind the consumption of the chemsex drugs. To calm the anxiety of vulnerability, to accept yourself with all these insecurities and complexes which you can have, with reason or without it, to overcome shyness, not to hate yourself. And we are speaking about some phenomenon which is called internalized homophobia. These drugs help to lose sexual inhibitions. They make us feel more attractive, to feel as desired, which I think it is a beautiful, nice objective which normal people in their normal personal life can have. These drugs help to escape feelings of rejection and loneliness. The serophobia is another problem for the men having sex with men, because in this environment, you can feel safe. Nobody asks you too many questions, and you don't feel you have to justify yourselves with the people who surround you, because all the people around you are more or less similar. Also, these drugs helps to solve or to forgive post-traumas, the childhood sexual abuse, the bullying, the traumatic migration processes that now we are living in the world with so many migration all around the planet. And for many men, these drugs may prove to be the only way out, actually. Now let's speak about how. Who, why, and how the sexual substances. Here we have three pillars of the substances which we use normally in the chemical sex. We speak about three basic ones, which is the crystal methamphetamine. You see here the common names, the street names, which can be Tina, tea, meth, cinnamon, amphetamines, glass, speed, whatever. Another one is the MA or methadone, and it is the methyl methcatinone, which is the Mephe, cactus food, meow meow, cat meth, MA cat, and so and so. And there is the G, which is the GHB, and this is the gamma hydroxybutyrate, and the GBL. The GBL, which is the precursor of the GHB, this one initially was used as the anesthetic, but it was withdrawn from the pharmaceutical market due to its low analgesic power and high epileptogenic capacity. And a part of these three, evidently, we use cocaine, Viagra, ketamine, and popo. So these are our substances. And then, speaking about the uses, I divide the uses into types. One of them are cooks or mixers, and these one really have an extensive knowledge of the pharmacology that they use. And another ones, they are kamikaze, and they are like that Japanese soldiers during the First World War who are going with their airplanes, struggling without knowing exactly where they are going and ready to die. From the moment of drug consumption, the cook mixes control the absorption, the metabolism, the plateau, and the elimination of all the drugs that they consume, though it is so difficult to understand how they manage to do it being so extremely high. And they combine afterwards this with the depressants and stimulants, changing one and another in the proper moment in a very masterful and artistic way. And they complement it oftenly with some hallucinogens if necessary. So imagine how can be one party of chemsex of 72 hours of non-stop sex with some 10 sexual couples in a single night, which can have a single user, which is oftenly completely not protected, with lots of possibilities of exposure to the HIV and to the sexually transmitted diseases. Just try to imagine the reality of this kind of events. I wanted to speak to you because we are doctors, and for us it is really interesting the mechanics of the function of the substances which our patients are using. So here is the list of the ones most used there. And the first of them is the GHB. The GHB, or called liquid ecstasy, actually it was invented, the name of liquid ecstasy was invented just to confuse the people, because the people were thinking about the ecstasy, which is the famous MDMA, which is the drug party, which brings you cheerfulness and empathy and helps you to have lots of energy and to dance a lot. So the liquid ecstasy is just the opposite effect of that. But it was sold with this name just to confuse the people, for that they lose their fear while buying, while experimenting what kind of substance is. So this one is a liquid, which is colorless, odorless, sometimes with a little bit salty or bitter chemical taste, depending on if it is GHB or GBL. And normally the route of administration is the oral one. When we speak about the desired effects, let's think another time about these purposes, which normally the guys who are using the drugs are looking to satisfy. The GHB and the GBL give you the intense surge of feelings of happiness and well-being. Doesn't it sound good? I think it does. It gives you the euphoria, the relaxation, the disinhibition. You can feel the feeling of drunkenness, excitement, sociability. It increases your tactile sensitivity. It facilitates and enhances the orgasm. To tell you the truth, sounds really marvelously. This drug produces sedation, anesthesia, and relaxation of the anal sphincter, which can help in these kind of relationships. And all this could be fantastic if not for the adverse effects and complications which this drug causes. And the reason is that the GHB is a powerful central nervous system depressant, which gives you dizziness, nausea, vomiting, motor incoordination, headache, drowsiness, and reversible coma. But it is not the most negative and the most frightening feature. The case is that the GHB produces the blockage of the respiratory center and brings death due to apnea, produces seizures in those who consume them, agitation, delirium, hallucination, psychotic symptom, and in the long term, it causes the severe dependence. The next drug, which is the pillar of the chemsex, is the crystal methamphetamine. And other names of tina, crystal meth, cinnamon, we spoke about them already a little bit. So this one, the crystal meth, is the famous pervitin of the Nazi army of the Third Reich. This drug was widely used among the fighter pilots in the Second World War. It kept them awake for 7 days and suppressed their receptors, making them feel less fear. This chemical could make them more lethal and effective on the front lines. The effect of crystal meth is that it hooks you into whatever activity you are doing at the time of use. If you are driving a car and consume the tina, you will drive without stop until your car your tank gets without gasoline. If you are popping pimples in your face, you will not stop until your face is completely destroyed. And that's why we often see the images, the photos of the drug addicts covered in marks and scars from popped pimples. This produces, a part of this, a full spectrum of sympatomimetic symptoms, which can give the hypertension, the tachycardia with risk of the killer arrhythmias, dry skin and mucous membranes with malignant hyperthermia, and the multi-organ failure. It is highly addictive. It produces erectile dysfunctions and a tooth loss in the long-term use. The next drug, which we are speaking about in these practices, is amphetamine. Amphetamine, which is commonly known as speed or elevators. They are white-colored pills or powder, which also have very interesting and very apparently nice desired effects. They give high energy, power, euphoria, the maximum alertness, increases attention, intellectual performance, and great communication skills. Another time, something what we are looking for when we are going to a party or when we are introducing ourselves to a unknown collective of people. And in the middle, there is the interest of the sexual intercourse. So these drugs also decrease the appetite. So they were used for losing weight in some times, and also were withdrawn, and also decreases the fatigue. This could be absolutely attractive. You know very well that some of the amphetamines are used even in the university by the pupils of the school to prepare themselves for the exam because of this increased attention and intellectual performance, which this amphetamine does. But here are the adverse effects. And these adverse effects are being the synthetic adrenergic potassium CNS stimulant. This produces the profuse sweating, increased heart rate, increased blood pressure, tachypnea, vertigo, the blurred vision, high risk of acute myocardial infarction, hallucinations, and intense paranoia with the prolonged use of these drugs. Next one pillar is the mephedrone, and the mephedrone, or called Mephe or meow meow, actually it is a plant fertilizer or the bathroom flavoring. This is what they use with the name of cactus food or meow meow. So it can be administered in practically all ways: oral, wrapped in cigarette paper, snorted, injected rectally, what is called booty bumping, and the mephedrone has amazing stimulation effect, gives you a great sexual arousal, extreme disinhibition, increases libido, extreme euphoria, elevates your empathy, and also gives the relaxation of the anal sphincter. But another time, there are adverse effects, and almost all of them, the ones we are speaking about in this presentation, finish with the multi-organic failure, cardiac arrest, cerebral hemorrhage, apnea, asphyxia, and death. And this one, like a good stimulant and an ectoxidant similar to amphetamines and ecstasy and cocaine, gives you the intense thirst, significant hypotemia, psychotic symptoms, convulsions, myofasciculations, cardiac arrhythmias, inhibits and make erection difficult, and this is why induces that the guys also consume the sexual enhancers. And these combinations of different group of medications can be another source of extremely severe medical problems. Popper is quite innocent in comparison with all of those, and this is why nitrite, the volatile liquid, and this gives, like in 30 seconds or in 2 minutes, the great feeling of euphoria, the desire of socialization, the excitement, the increase of sexual potency. It intensifies the orgasm and delays another time the anal sphincter. Everything seems so positive, attractive, and useful. But also it gives blindness due to the retinal damage and glaucoma. It gives anemia, and acutely for me, as the emergency medicine doctor who is going with the advanced life support ambulance to save the life of these guys, they suffer from vasodilation, hypertension, hypoxemia, myocardial infarction, cerebrovascular infects, hepatorenal toxicity, hypovolemic shocks, and what is less important for us, erectile difficulties. When we speak about MDMA, well, this one is the ecstasy, which all of us will know since quite many years ago. We've heard about this since our adolescent years. Now we have a new version, which is the pink cocaine or 2C or 2CB. This one actually is a mixture of several drugs, and nobody knows, even the drug dealer who sells it to you knows which percentage of which chemical is inside the pink cocaine or 2C. Normally, it contains MDMA, LSD, and ketamine. We speak about the feeling of great stimulations, loss of empathy, acceptance of yourself and the world around and the connection, but then come the adverse effects, which can be all the entire spectrum another time of sympathomimetic symptoms, which will be tachycardia, which will be arrhythmias, angina, myocardial infarction, malignant hyperthermia, heart stroke, anxiety, and so, and so, and so. And the last page of the list of the drugs which we are speaking about is cocaine, ketamine, and the erectile dysfunction drugs. I think cocaine is something what we really, really know since the 18th century. Nothing specific to speak about. We know perfectly which euphoria, loquacity, talkativeness it gives, the mental acceleration, hyperactivity, hyperalertness, and so and so. And is just to remember that the adverse effect of these substances are psychotic symptoms, paranoid thoughts, depression, insomnia, loss of appetite, intense psychological dependence, and psychologically, physically, and for the acute emergency medicine, it is hypertension, it is tachycardia, it is high risk of arrhythmias and ischemic heart disease, and very high risk of cerebral hemorrhage. And when we're speaking about the ketamine, I think the last one, which I will explain you among these scape of substances, well, this is the powder, crystals, or liquid, which is called vitamin K, special K, or keta. Also can be introduced in the body in the diverse ways, and also have very nice desires effect, like relaxation, like feeling peaceful, dreamy, the perceptual dissociation, empathy, powerful anesthesia. But the adverse effect of the ketamine are really killing. Okay, they give anxiety, panic attack, delusional ideas, dissociative anesthesia with catalepsy, with rigidity and motor paralysis, with amnesia. And they give tachycardia, hypertension, increases the cerebral and myocardial oxygen consumption, increase intracranial and intraocular pressure, gives coma, seizures, stroke, asphyxia, and cardiac arrest, and again, death. So these are. And then here there is one incredible phrase from my collection of testimonials from the Chemsex users. Just listen attentively what it says. If you're still in a somewhat good state, where you manage not to use drugs during the week, by Friday you are already craving it. You use drugs on Friday, Saturday, and Sunday, and if you make it to work on Monday, it's a hangover. You come home exhausted, sleep, but it is not restorative. You probably don't get your life back until Wednesday afternoon. And by Wednesday, you think that you haven't gone to the gym, that you are getting fat, and that no one will invite you to the parties. You go to the gym for 2 or 3 days, and then it's back to the party. In all this, you are not thinking about your family or friends. Your life is sex, survive, sleep, drugs. There is no thought that isn't about drugs. Just to remember, sexual practices have different scope for the sexual transmission of different pathogens. And another phrases of my favorite collections of the people using chemsex or treating people who use chemsex. This one is one of the directors of the health center from Madrid, who is taking care of sex workers and people with sexually transmitted diseases. He says the problem is not whether you have syphilis or not. The problem is that today is Wednesday and you haven't gone to work because of the withdrawal or because of the depression you're suffering from. And another one, when you arrive for a session, you are very clear about which drug you like, but then something gets completely distorted. And if someone shows up and tells you that they have ketamine, you're going to take it, ketamine or cocaine or whatever. You know it makes you feel bad, but you take it anyway because your goal is to get better. And better is to be more high. So here is a question. Chemsex is sex problem or drug problem? The nature of public health risk and the need of harm reduction is here in this list. We are speaking about the sexual marathon lasting more than 72 hours. Their extreme sexual disinhibition and extreme sexual practices with multiple partners. I told you already, some 10 in one single night. These sexual practices used to be very violent. Normally, they are completely unprotected. The interactions of the drugs which the guy used are unpredictable. The intravenous use is very increased in the last time. The HIV patients have very poor adherence to antiretroviral treatment, and the PrEP and the post therapies, which people consume 10, 20, 30, 40 times in a single year. Here are the comprehensible statistics of Chemsex. HIV positives, more than 50%. 45% reported an average of 4 to 10 partners per Chemsex session. 70 reported not having had clean sex in the previous 6 months. These people don't know how to have pleasure and how to have normal, pure, sober sex. For now, if there is the rainbow stimulation of the multiple amount of drugs, they are not able of having sexual relationships. Another time, then we are speaking about sex problem or drug problem. And here are the phrases of my favorite authors, philosophers, doctors. One of them is Gabor Mate, who says, drugs aren't the problem. Drugs are just an attempt to solve the problem. And the David Stewart from the London 56 Dean Street Clinic says, chemsex isn't the problem. It is a symptom in gay culture, which we try to medicate in our bedrooms. And now I thought of showing you one very, very shocking and very explicit video. This is a real warning. We are all doctors. Our patients who come to our consultations have and live this reality. So please, will be shocking. Okay. Shocking, stressing, frightening. But this brings us to the concepts of the chemical submission, of the chemical vulnerability, and the criminal purposes which can have the people who are using our lability, our unconsciousness to perform their criminal purposes. When we're speaking about the chemical submission, we speak about the administration of psychoactive substances to a person without their knowledge or their consent for criminal purposes. And these alerts the victim's states of alertness, consciousness, judgment, makes it asleep or awake, but under the attacker's control in all the moment. So the sexual assault is the most common crime. The requirements of the drugs which we use in the chemical submission. You remember we were speaking about the drugs used in chemsex and their requirements. So here are the ones of the chemical submissions which are completely different. We speak about the drugs which must be fast-acting and short-lived in comparison with the chemsex. Poor laboratory detection due to its kinetics. It must produce the uncharacteristic symptoms, which doesn't mean nothing when you describe your feelings to the people. Easy available, also buying everything in these times online. With oral administration, must be discreet, must be tasteless or masked. They must be active at low doses, and the offenders normally have the extensive knowledge of its pharmacology. Here are the substances used in chemsex and in chemical submission, and we see that practically no one of the stimulants that we were using in chemsex are interested for the offenders of the chemical submission. The one which really is perfectly working for them is the GHB or the GBL, with these sedation, euphoria, disinhibition, drunkenness, sexual stimulation, but at the same time, drowsiness and loss of the motor control and psychological control. dependence, hallucinations, and so on. And in this page, the only one which serves to them, it is the ketamine, because you remember also this one which gives the alteration of perception, the confusion, the dissociation, and it makes the consumer to be docile and manipulable. Then the rest of the chemicals which are used have quite few to do with the chemsex. And the first of them is alcohol. After that go benzodiazepines, the GBL or GHB, which we spoke about, the liquid ecstasy, the scopolamine, or in Latin world, we call it burundanga, the zopiclone, the ketamine, and can be used the fentanyl and the nitazens. I don't know if you know what the nitazens are. It is just for you like to know. It is the informative note. Nitazens are synthetic morphines. These synthetic morphines, it is something very new in our world, let's say, and it started since the Taliban have closed opium plantations in Afghanistan. So in Europe and United States, they've lost a huge production and selling of the natural opium. And then in the chemical laboratories, they created one horrific substance or substances that they are 300, 500, 1,000 of them of different types of new psychoactive substances. And the nitazens, for example, are 1,000 times more powerful than the morphine. So imagine how deathful it can be for the consumers, and we are the doctors who will have to attend these patients. When we speak about benzodiazepines, there is nothing very special new which we can speak. The rohypnol or flunitrazepam, we refer, I am just begging pardon because many of these very specific and medical terms I cannot pronounce very correctly in English. Anyway, try to read and catch well the idea, because all these substances, we know them very well. So the rohypnol is a strong sedative sleeping pill. This illicit use was discovered in 90s in the United States, and oftenly it is used slipped into the alcoholic drinks. Immediate side effects include dizziness, disorientation, nausea, feeling hot or cold, and difficulty articulating the speech. Scopolamine or burundanga is called in another way sleep kiss, zombie dust, or devil's breath. And this is a competitive agonist of muscarinic cholinergic receptors in both cholinergically innervated and not cholinergic cells. So it was called the truth serum and the CIA and interrogations in 1960s in the Russian KGB and in the second or after the Second World War. It was the truth serum which made the victim docile and obedient to all your orders and all your questions.
Chinese women.
The day trade drugs. Let's speak about the GHB very briefly, because this substance we already analyzed very well and know perfectly what's going on after the chemsex part of this talk. This is the CNS depression. We know that it is synthesized from the GABA neurotransmitters. It is tasteless, odorless, liquid or power. And what is really important for us is that it can be lethal when mixed with alcohol. Onset side effects of the GHB are within 15 minutes. And they include sleep paralysis, agitation, vomiting, hallucinations, slower respirations, blockage of the respiratory center, and death due to hypoxia or asphyxia. Another day trade drugs are zopiclone, which is a GABA A receptor agonist, which regulates the chloride ion channel opening, and the ketamine, which we were speaking already about, and this is the dissociative anesthetic, which made you completely docile and obedient to the wish of the perpetrator, of the attacker, produces the state of deep confusion, dissociation, rigidity, coma, and makes the users completely manipulable. And let's speak a couple of words about alcohol. Is it a date rape drug? Without any doubt. More than that, it is the most common since the beginning of the history of the humanity one. Under the influence of the alcohol, it is harder to think logically and clearly. It is harder to set boundaries and make good decisions. It is harder to appreciate the potential danger of an approaching situation. It is harder to say no to sexual advances, harder to defend oneself if a sexual assault occurs, and more likely to lose consciousness or experience memory loss. And if we are speaking about the attackers who can drink the alcohol, drinking often loosens inhibitions, triggers aggressive behaviors, contributes to a lack of common sense and feelings of invincibility. I cannot pronounce this word. Alcohol is present in 40-65% of sexual assaults. Risk factor. Alcohol accounts for 75% of chemical vulnerability or chemical submission cases. And here is a series of great photos of one campaign made, I think, in Great Britain, speaking about the sexual assault, which can be physical, verbal, visual, auditory, and any action that forces a person into unwanted, non-consensual consensual sexual contact. Just to remember some examples of the sexual assault. It is the voyeurism, which is seeking sexual excitement by observing naked people or people engaging in some form of sexual activity, but it doesn't imply any subsequent sexual activity on the part of the voyager. Then there is the exhibitionism, incest, and sexual harassment. But what we would like to finish speaking in this presentation is the issue of the date rape or acquaintance rape or drug-facilitated sexual attack. Non-consensual sexual activity associated with misconception of consent. This is why it is grossly underreported and associated with the long-term post-traumatic syndrome. This is used both for men and for women, and the term date rape can be misleading because the person committing the crime may not be dating the victim. Rather, it could be an acquaintance or a complete stranger. Date rape accounts for 60% of reported rapes. 1 in 4 women in Canada, there is one work which I've read which was really impressive in the results. 1 in 4 women in Canada are sexually abused. 51% of Canadian women report having experienced at least one incident of sexual violence since the age of 16. It is estimated that 1 in 10 adult men are sexually abused. 4 out of 5 female undergraduates attending university in Canada report sexual violence in their dating relationship. And these, which I marked in pink, was something frightening for me. Well, frightening, but it was a sincere response of the guys who were interviewed in the University of Canada. 60% of university-aged males report they would commit sexual assault if they were certain they would not get caught. How do you feel about this? Well, this is the photo of this girl. Her name was Lucía Pérez. This happened in 2016. This girl was 16 years old. She has been drugged, raped, and impaled, and her body was washed before being transferred to a first aid room on the beach of her city. Until today, this year, they are celebrating trails. They are still in judgmental courses trying to reveal if the people who drugged, raped, and impaled and then washed the girl were really criminals or not. And meanwhile, during all these 10 long years, in all the media of the country, they have been scrutinizing the private life of Lucía in front of all the country, down to the most intimate details of her life, speaking that the girl was a not serious girl, that she went voluntary with the 3 drug dealers who were waiting in the doors of the university for minors to recruit teenagers and to sell them drugs. What we are speaking about, that neither the intoxication, nor voluntary drug use, nor intoxication justify the rape and less the murderer. The victim is not to blame for being assaulted. The misconceptions of the date rape. This really hurts. One of the misconceptions is that a woman who gets raped usually deserves it. This was the case of Lucía, which they were discussing during 10 years in the media of the country, because she has been flirting or has been seen kissing the rapist before being raped. The acquaintance rape is committed by men who are easy to identify as rapists. It is not like this at all. Women who don't fight back haven't been raped. Amazing. Once a man reaches a certain point of arousal, sex is inevitable and they can't help forcing themselves upon a woman. Really? And certain behaviors, such as drinking or dressing in a sexually appealing way, make rape a woman's responsibility. And here is another victim. This is from 16th of March. This girl, the Ukrainian OnlyFans model, just young girl of 20 years old, she was found with broken arms, legs, and spinal column after attending a private party in Dubai. Some leaks claim that the victim had drugs in her bloodstream, not surprising at all with the dynamics of the sexual parties of the nowadays. The police maintain that the young woman entered a restricted building and fell from a great height, but the family doesn't accept this version because Mariya, which was the name of the girl, didn't have any documents on her phone with her when she was found, raising further suspicions about what really happened during her disappearance. And well, Raquel and Vinny will speak to you much more in detail about this. But here you have official pages which are prepared for the tourists, which teach you what to do not to be spiked when you are traveling. And these are some of these recommendations. Wait, came back. Don't accept drink from other people whom you don't know. Open containers yourself. Keep your drink close and under close supervision at all times. Don't share drinks. Don't drink from punch bowls or other open communal containers. If someone offers you a drink at a bar or party, go with them to order your drink and watch how the drink is poured and bring it yourself. Don't drink anything that tastes or smells strange. Take a non-drinking friend with you if possible to make sure nothing happens. And if you notice you've left your drink unattended, throw it away. If you feel intoxicated and haven't been drinking alcohol, or if you think the effects of alcohol consumption are stronger than normal, seek help immediately. Here are some modern ways how we can filter if our drink was spiked. And here are very interesting, very sad advice for the women who can be conscious and experience the sexual assault. If you are conscious and experience the sexual assault during the attack, try to remain calm, to avoid insults and pleading. Try to retain as much information as possible about the attackers, their characteristic, their complexion, their age, their blemishes, tattoos, and so. This one is very interesting. Try to disconcert the attacker through unusual behaviors like vomiting, urinating. I am not sure that if you are raped in this moment, you will be very able to control this kind of behaviors. Well, can be interesting not to reprime it if suddenly you feel to do it. Yell fire instead of help, and offer resistance as long as there is only one attacker and they are unarmed. The psychological phenomena found in drug-mediated rape survivors, I think Vini will speak to you about that, but shock, disbelief, flashback, emotional lability are the most common one to expect. What to do if you have suffered sexual assault? Raquel will speak to you about that. And if you have a friend who was the victim of the rape, they are advisors for you or a healthcare worker how to behave with the victim of the rape. Stay calm and approach the topic normally. Don't question, don't blame. Don't be offended or angry if the victim didn't talk to you about their problem immediately. Show understanding. Don't be suspicious or question their words. Try to alleviate feelings of guilt. Don't change your behavior or relationships with the victim. And one which I like really very much, don't attribute future problems to the assault they experienced. And remember, always, if you suffer sexual assault, there is only one person to blame, and that person is the aggressor. Here are my contact details, and just to remind you that this was a joint work of the WONCA special interest groups in family violence, emergency medicine, and the WONCA's Women and Family Medicine Working Party. And I give the place to Raquel and Vini. Thank you very much.
Thank you so much, Elena. I'd like to just introduce Dr. Raquel Gómez Bravo, who is a family physician from Spain, now working in Luxembourg. She's co-chair of the WONCA Special Interest Group on Family Violence, and she's going to present on the approach to victims of drug-facilitated sexual assault. Thanks, Raquel.
Can you hear me? Yes? Yes. Thank you so much, Elena, for your comprehensive overview of this situation. From my part, I'm going to make you a brief overview of what will be our response from primary healthcare. I think it's very important to remind that primary healthcare is offering us and the population the accessibility. We have a frequent contact with the victims and survivors. We offer continuity. We build a trust relationship, and one of the points that make us stronger is the longitudinality. So we are often the first or point of contact, emergency cares and primary health care with the victims. And we have acute situation, like Elena was mentioning, but also these persons who have been suffering any type of abuse or violence, they might have consequences in their lifetime, and the accessibility that they have in primary care is truly important in order to offer them the care that they deserve. Elena was mentioning about chemsex. It's important to not judge to any patients that we are attending in our consultation. I said that there are different practices that we might or might not share with our patients, but our position, our role is to not be judgmental and to identify where's a risk in this kind of practices and what kind of complication or what can this risk lead us to any action that we are going to take to prevent or to treat. So these risk indicators that Elena was mentioning already, so the number of patients, number of contacts, or the non-protective relationships, or the contact with infections, or the frequent use of pre-exposition treatment for HIV, for example. It's important also because these people engage with services, so it's important to know what kind of relationship they have with the healthcare services, because they make a very vulnerable population. So we need to know that they're often, as a vulnerable population, they will be treated in a different way, because normally they have a different relationship with the healthcare system. Also, they have a poor adherence to treatment. And on the other side, or red flags, we have to identify when they have frequent episode, like Elena was mentioning, because this could suggest a dependency. So when we have addiction behavior that make us be at higher risk. Also, when they are using prolongedly this kind of drugs, of substances, what kind of consequences we might have in our consultation that can be, like Elena was mentioning, also in their daily life, not only the risk of being infected, but also what is the consequences in the whole life. This is especially important for us because it's opening a window of engagement with our patients, and we might be able to assess, depending on the moment that this patient is attending our consultation, what is the phase of change that Vinicius will speak later about it. It's very important for us to know what is our role. We have to be very aware that the decision is on the patient side, not on our side, and we have to be respectful of the every step of the way and offer information and treatment at any point, especially reducing harm, taking care of their mental health or their addiction, making proper referrals or follow-up. It's very important that we know our key position in a multidisciplinary team. And often we tend to solve our problems ourselves, but in the case of abuse and violence, we need to count on a multidisciplinary team to provide proper care. Monitor, like Elena was mentioning, drug dependency, withdrawal, and important, ensure the treatment necessary for each person. There are different screening approach. For example, if we speak about Chemsex, I will pass briefly about it. Are used in the health clinics in for example, the 56 Ding Street in London, where they explore the type of substance that they're using, the frequency, the patterns, their impact in the sexual health, mental health, social life, and the state of the readiness to change in this person. And they even make a contract agreement. Other tools can be, for example, the screening tools, where we make open questions to explore what is the situation, or also the assist from the WHO, where we identify the harm or the dependent use of substances, and can be very tailored to this context. Also, drug abuse screening tool, or a combination of sexual health history and risk assessment, also with open question to make a profile where we know what is the situation of this person and what could be the risk. It's an example of kind of open question that we can use, again, being non-judgmental and offering a safe environment where the person can identify that they can speak openly with us, and they can share with us what is their normal practice, what did they do, and where they identify that the risk, if there's any risk, if they identify that there's an impact in their life. This open for us a possibility to offer primary prevention and education. No? The first primary prevention will be preventing the initiations of risk practices, or reduce the risk if this occurs. For example, sexual education is is key in this section, and normally it's not only us the one to provide, but also we do it in combination with other sectors, educational sectors, community, family. We have to target this population that we are mentioning that could be a higher risk, assess how can we prevent ourselves for contacting other diseases, promoting a safer sex, sober spaces, with the community workshop, or addressing other factors like Elena was mentioning. Why are these patients using this kind of substances, or if there's any underlying factors that we can treat. If we go to secondary prevention, it's very important to identify if we can make an early intervention and what kind of intervention we can do. And it's important with the routinary screening, asking for any kind of behavior, if there's an urinary infection, for example, or if there is an identification on a infection, recent infection, making brief intervention, screening, offering always psychological support or referral if necessary to other services that are able to provide a proper answer if we cannot do it from our consultation. We have to be very aware what is our role and where are the limits that we might have in our consultation. Some colleagues don't have enough time or don't have enough resources, and that's why we make always the emphasis that we are part of a multidisciplinary team, and it's important to have a key person that the patient can identify with and build this trust relationship. The tertiary prevention will be to minimize the complication and support to this patient, offering a structured substance use and treatment programs, sexual health and HIV management with close monitoring and support, long-term psychological therapy, support groups, or integrated care pathways. When we speak about chemical submission, like Elena was mentioning, I wanted to highlight the importance of this situation, because we are speaking about sexual violence. And unfortunately, we always repeat these numbers are underestimated and underdiagnosed. We know 1 in 3 women will suffer or experience physical sexual violence in their lifetime. And the impact of that is huge. As we all know. So that's why important is to keep in mind that these situations are much more frequent than we would like them to be. And we always use the image of the iceberg. We only see the top of the iceberg, these terrible cases that Elena was mentioning of violence and abuse and death. But unfortunately, there are many more that we are not identifying. This is important evidence that we always use when we refer to victims of violence and abuse. They use healthcare services much more often than other patients. They trust us as professionals that they will open us and disclose. But for that, we need to ask specifically for that. We need to ask for violence and abuse in our consultation. It's important that we ensure our patients, victims, and survivors that if they have a thought, if they have the sensation that they have been abused, or they have been suffering chemical submission or experience a weird situation, it's very important that they go to a safe place, seek immediate medical attention, report the incident, try to document everything that they remember, and get emotional and legal support. This is a very stepwise approach, but it's very important not to question this person. If something is wrong with my body, I know my body, and again, we are not here to judge. We are here to provide medical care and support. This is the initial attention evaluation that we should do in case of emergency situations. So if somebody believes that something happened, like I said, we identify red flags and weird symptoms, and we had to consider potential sexual assault. And here you have the details. So if we have any presence of fluids, unexplained injuries, sensation of dizziness, loss of consciousness, anything weird that you can explain is enough to report it. It's important for us as professionals to understand that in this situation we had to make a collection of toxical samples, urine, blood, or hair. Depending on the type of samples, we can have information on what happened in the last 48 hours or in the last 5 days after the incident. So it's very important that we keep in mind we are in a unique position to offer information and collect samples. We need to always do a physical examination, like Elena was mentioning, being very systematic and reporting every detailed injury. Of course, trying not to clean any part of the body. We always say the same: don't change your clothes, don't clean anything, just come to the point of care that is closer to you to report any suspicion of sexual assault or abuse. We also have to provide medical legal aspect. Like I said before, we are part of a multidisciplinary team. There are always forensic doctors, gynecologic service, state security forces that will be there to provide the proper care along with us. And we need to inform the victim about what are these steps that need to be done, and they don't have to do it alone. It's important that we offer support for that, or put them in touch with the specific services that will help them to go through this. I like very much this acronym for WHO. We save lives. Is very ambitious to say, but lives is the acronym that we have to always keep in mind. We listen in an empathic way, not judging, inquire, open questions to this person, validate, and his safety is very important to identify risk flags. And also the potential risk if this person is going back to the house and there's a risk at home, and support this victim. You also have the other approach, which is the 5 R's that our colleagues from UK were identify, recognize, announce, respond, risk assess, refer, and record. Again, our role is key because we are in a unique position to offer help to this person who are completely lost and offering and normally suffering a very traumatic situation. As Elena was mentioning, our duty is to remind them that they are not alone, that this is not their fault, and that we are there to help to coordinate resources, to provide a follow-up, and to guide this person through the care provider. For us, it's very important to identify that this person, this victim, can go over this traumatic experience and have hopefully another type of life. And that's why we were inviting Vinicius to give us some highlights of how this could be done. Here you have my data in case you wanted to contact me, and I will leave him as we are very short of time, I will leave him now the space that he can provide us his expertise, how this psychosexual care can be done in situations of chemsex and chemical sexual submission.
Thanks very much, Raquel. We've now got Dr. Vinicius Jobim Fischer, who's a PhD in psychology, master in sexological sciences, and a certified psycho-sexologist from Brazil and Luxembourg. He will speak on psychological and sexological care in the context of drug-induced sexual assault and chemsex.
Thank you. Thank you very much for the space, for the invitation. It's an honor to be here and to be able to share a little bit of some of the activities that we can do under a psychological and sexological perspective in this multidisciplinary approach that we need to have. And for us, psychologists, stay what's not acute phase. So I hope that I can briefly explain a little bit to you some of the elements of the therapies or of the treatments that we can offer for people that have experienced either chemical submission or who are engaging in chemsex. So the topic is this, as it was already followed. I just put here the two in separate because, in fact, under our perspective, the treatment can have some similarities, but can also have some differences when it is chemsex and when it was a chemical submission situation. So if we think about the chemsex, usually the steps that you're gonna do is to initially understand the reasons of use. I think that Elena described super well how varied can be the reasons and the motivations that might let people to experience it and perhaps engage, and then what's going to be the frequency and intensity that they're going to do these behaviors. Then, depending on this assessment, we are going to conduct therapy that is similar to other substance use or disorder treatments. And we need a special focus on the motivational interview. I think that both in Elena's presentation and in Raquel, this part of assessing the readiness for change, that's going to be one of the core elements when we are dealing with people that do Chemsex. And that's going to be different, of course, from a chemical submission assault. So here we have some reasons. I think that Elena already described them quite a lot, but it's important for us to really have this open, even if I know that your contacts are usually short-term, or if it's a case of emergency, is much more limited in time. But we need at least to have the perspective that the reasons why I engage in chemsex are varied, no? So they are not as specific. And the more specific is our assessment, the better we can conceptualize the cases and the reasons that make the motivation, the higher the chances that we are going to be able to support this person either in harm reduction or in engaging to change and perhaps stop this behavior, if the cons are outsourcing the pros. No? So here we have like the desire to fit in, the other psychiatric comorbidity, relationship situations. Quite common that the initial that the initiation is going to be through friends or to partners. So there is this element of curiosity, the fear of rejection, and so forth. So this is something to have in mind. Then the negative consequences. I mean, Elena super well described all the acute consequence that we can have from the effect of the substances, and also went on that. So here, when I look or when I receive people that engage in that, it's more long-term consequences, that we have to assess. So I think, as in the cases that Elena was mentioning about, like these testimonies of spending days without being able to go to work. So in fact, we have some consequences that are not necessarily psychological or medical, but that relate a multidisciplinary approach with social workers and help and mediators, because there are housing issues with expending too much money, risk of unemployment, besides all the mental and physical health situations as described. And then in the sexology clinic, when it's not just the psychology as mentioned before, the difficulties to sober sex is one of the elements that we have to be particularly attentive, because in fact, if I'm just engaging in sex through these other elements that heighten or potentiate my responses, when I am experiencing a moment without the drugs, this experience might be difficult to understand, to process. So this is some of particular attention in a more prolonged therapy session, psychological consultation. This is very touchy, but there is this differentiation, or some authors at least make this differentiation about what could be a non-problematic versus a problematic use of chemsex. And I found it important, I guess, that the assessment of the non-judgmental and the more individualized care possible to our patients is important. Indeed, the videos that Elena showed are super shocking, and these really do happen. But there are also some people that, at least for periods of time, can use just some specific substances, or can have some control on the frequency of the moments that they're going to go to parties. I had patients who created smaller groups of parties in which they would do that, but with a limited amount of people and just with friends. So there can be, to a certain extent, a non-problematic, or at least less problematic use of chemicals. And then, of course, the more problematic, I think that it's already more than covered by the previous presentations, is that it can really get out of our control, and the negative consequences, the addictive behaviors and the impairments on physical, psychological, and social level can be extremely hard on people. No? So this is part of our assessment. In our steps, no, in the psychological or psychosexual treatment, the history taking, very common to all of us, to UGPs as well. The individualization of the case, and also this element of the case conceptualization is going to be a super important focus. So what are exactly my reasons? It is by other comorbidity, it is by some peer pressure, by intimacy, by a past situation, depending on the reasons that my client has. We are going to have to tailor more the treatment that we are going to offer. No? So after this case conceptualization, then we would move to the motivational stage, and that's going to be the core to see what exactly we can do. You can pass, Raquel. Thank you. So motivational stages. No, remember that we can enter and leave at any stage, and we can be motivated in one day and lose our motivation for change on the following, or we might be motivated for some substance and not to other. No. That's very important for us to assess and to somehow continuously assess in our patients, because the less prescriptive we are, the higher the chances of change. No? So if we are in, let's say, pre-contemplation phase, I'm not even considering this problem. In contemplation, I acknowledge that this behavior is being problematic to me, but I'm still not motivated to change, or I still don't feel that I have the strength to make the change. Then there is another phase in which I am determined. Oh, this cannot go on. What happened last week was too much for me. I need to change. What can I do? Then we enter in determination, action, and following the maintenance of this sober sex, for instance, or having some lapse or relapse. Raquel, please. Yeah. Depending on the motivational stage, so like let's say that I'm starting to be contemplative, I'm seeing that this might be a problem to me. This is how David Stewart was establishing his care plan. No? So you have to reflect on the use of the drugs that we have, choose a goal. What is my goal now? And then again, it's not our job to decide the goal of the patient. Our job is to support their decision and to understand what might be triggering the responses that they are giving. You know, the goal could be to stay some days without. The goal could be to use just one specific drug. The goal would be to leave after a certain limited time, and then usually we would need some support, you know, so let's say a friend that could pick up or some other source. After that we have this goal, then we establish a plan of how can we achieve this goal. And in order to organize this behaviorally, we need to identify the triggers and the vulnerable times. No? Chemsex in the big cities is super related to use of apps. So for instance, if we can not use the app, we might diminish a lot our chances of going. No? Or I can identify that, I don't know, Thursday night, Thursday evening is a moment in which usually me and my friends, we always go to this party. So I already know that the Thursday is a very sensible day to me, in which I might be more craving or might be more thinking about doing it. So this identification, and then if it's the decision of the patient, do the strategies to the support of the abstinence or of not using the substance. Then what I haven't spoken as well. So we will, Raquel, if we could go back to the slide, go one more. Yeah. So this would be the point 4. So after we identify these motivational stages and set the goal, we would be engaging in either harm reduction, if the person is not motivated or is not determined to take actions to stop the use. And if the person is motivated and wants to try to stop the use, we would engage in cognitive behavioral therapy for substance use. We have already a lot of data of protocols of cognitive behavioral therapy for substance use with good results. And we need to include some elements that are more related to sexuality, to the concepts and beliefs of sexuality, mainly related to the difficulties with the sober sex or with the consequences of sexual difficulties, as Elena was saying, that the long-term use of some substance might generate erection problems and other sexual difficulties. If treatment is successful, we would end up doing relapse prevention. That would be the same as the maintenance phase of the motivational treatment and assessment. Now, please, Raquel, you can move to the other part. Sorry for that. Very different from the approach to Chemsex, that would be for situations in chemical sexual submission. No? The main difference initially for us in a treatment that it's not going to be acute to treat intoxication is that in this case here, there was no voluntary entrance in any moment. No, that's an assault, is a completely violence. While in Chemsex, usually I enter to these groups or I go either to explore or by invitation or by voluntary decisions. No, the left image is Gisele Pellicot. I don't know if everybody is aware of her. She was very famous in the press now, in Europe at least. Was a case that was found in France of a systematic raped. So her partner would be doping her and would invite people to go to their place to systematically rape her for many consecutive years. I think that the trial was already done. I think that's already final, the decision last year. But it was something that was very shocking, you know, in a systematic way as it was doing. And the other element is a flyer of a study that was done in Yale. That's just for us to be attentive that there is a lot of situations in parties, universities, in which you have to protect our drinks, for instance, not to have these involuntary response and interactions with drugs, as Elena also previously mentioned. In a situation of assault with the chemical submission, we would have to start already in the case conceptualization phase to try to understand to what extent this experience is configuring a case of post-traumatic stress disorder. So that would be very important in the initial phase, and also see if there are other comorbidities assessing that. No? The importance to see what do I think, what do I believe about this experience. No, I don't know how intoxicated I was. It's something that I have a blank memory, that I have no memory at all. Was I partially awakened? Do I remember feeling things during the situation? Because this is going to have probably impacts after when we are going to be doing imaginary exposition and the treatment, and it will also impact usually on the amount of guilt and shame that is perceived by the victim. No, we are also going to assess the degree of physiological activation while narrating us the situation, and also, of course, the degree of impairment and distress that this is having in the daily life of our patients. No, the second phase would be the treatment itself. So then, if there is PTSD, we would go to the cognitive behavioral therapy for PTSD. You can include some mindfulness-based present moment awareness training, or we could provide EMDR treatment. No, and after this trauma therapy is provided, we would include some elements of sexological rehabilitation, that it's not just not suffering that much from the traumatic experience, but also being able to have a meaningful sexual life after this event. The CBT for PTSD is already very. We have a long history. We already have a lot of protocols, a lot of studies with evidence for that. This book is still valid, and I think it is like from 2002 or 2003 from Edna Foe, in which we have protocols to assess and to conduct that in a much length therapy than the consultation. And the elements of the treatment would be the psychoeducation about the reactions of the trauma, training of relaxation techniques. That's important to differentiate what is the physiological arousal that I can have when remembering the situation that I lived, from a full re-experience of the situation. Also, the training here is to see that from time to time I might have some reactions, how to calm down these physiological reactions while seeing that I am not fully re-experiencing the situation of the assault. We would move to the imaginary reliving of the rape memory, progressive exposure of these discomforts, of this physiological activation, and after the cognitive restructuring with the changing of distortion beliefs and thoughts that we can have related to the experience, as for instance in the previous presentations, the situations of it was my fault, I am dirty, I was responsible for what happened. And after, if the trauma is already diminished, as I said, then we would go to the progressive exposure to sexual encounters, to sexual contact. And then for that, again, the multidisciplinary approach is going to be even more important, both with helps of pharmacotherapy when needed, or with the help of physiotherapists, for instance, when needed. And thank you very much for the invitation.
Thanks very much. And thanks to all of our three speakers. It's been wonderful. Sorry, we have run quite a bit over time, but I'm sure our speakers would be happy to take any questions if anyone has any questions. No questions? Well, thank you so much, everyone. And it's nighttime in Australia. Have a good night if you're in Australia. Have a good morning in Europe and wherever else where you are in the world.